Hello, everybody. Thank you for joining us here in Oxford, and thank you for joining us online for this lecture series on AMR surveillance best practices with Dr. Geetanjali Kapoor. Today, Dr. Kapoor will be continuing with her discussion on AMR surveillance in human health. And before we do that, I'm just going to mention a few housekeeping items to those in the room. The fire exit is straight ahead out the door to the right. And then we have a series of housekeeping items. This lecture series is being recorded and will be shared on the Global Health Network platform. To automatically translate the speech to subtitles in your chosen language, please navigate to the closed captions function and select your language. Due to the number of participants, your video and microphone have been disabled. Please use the chat function to introduce yourself or to report any technical issues. Please use the Q&A function to post your questions and comments. You may do so anonymously. Thank you very much. And without further ado, I'm going to hand over the floor to Dr. Kapoor.
Thank you, Barbie. And good morning to all of you. Good afternoon, depending on where you are. I hope you had found the first 2 days fruitful. It helped you in some way in understanding what AMR surveillance is about. And we'll do a quick recap on what we have so far done. So I'll have the agenda in front first. So the day one was basically an overview. It was very general to get you all into the momentum on what surveillance of AMR is all about. What are we basically trying to achieve at the end of this 5-day series is to be able to confidently set up a surveillance system in any kind of a geographies or scope. It could be a single hospital, it could be multi-centric, national, regional, global, whatever. So giving that kind of structure and framework on how you can go about. So the first day was around the importance. We know it's important. We'll not get into details on the burden and everything, but that was discussed on the first day. And of course, we also showcased the global efforts that are happening, various platforms, documents, such a big group of stakeholders that's actually working on AMR mitigation, of which surveillance is one of the pillars. Then on the same day, we also got a little bit into understanding how the tests are done in the lab, what are the different kinds of phenotypic, genotypic, we went into all that. So surveillance is not just public health, it's also having a lot of component on some technicalities, which anybody in the surveillance team should be aware of. So that was the first day. Second day was yesterday, and now we basically focused on the strategic bit, on the importance of having stakeholder engagements. How do you start? What's the first step once you have been awarded either the grant? So a surveillance program can be as an independent exercise in your hospital, not funded by an external partner. You just decide that, okay, we need to do it, we need to support global efforts. So not necessarily it's because an award has been given, or it could be as part of a public health program. The team applied for a proposal, they got it, and then one of the objectives was to strengthen surveillance or establish a surveillance system. So that was all that we had discussed so far. Yesterday, there were 4 main steps that we basically looked at. We looked at the first level, which is going to be your stakeholder engagements. How do you make a team? Who all should be there in a surveillance team? And there was a very nice question that somebody had raised. If we are all from different skill sets, are we really cut to join this team? And the answer is yes, because it's always a cross learning. Everybody brings something on the table, but of course it's important to have somebody who's a technical expert on microbiology or laboratory testing or infectious diseases. That kind of profile definitely helps for the team lead to lead this program, because it is just not a non-technical kind of a program strengthening or program establishment. It's more also to do with with real microbiology tests. Now, today we are going to get into the technical bit. So when I say technical, I basically mean how exactly will you now get on ground? What are you supposed to be doing if you have all the other things in place? So you have a team, you have done the handshake with your funder, you have done a handshake with your different stakeholders, maybe if it's at a country level. So the Ministry of Health is also now knowing that, okay, this group of this project team is going to now start this exercise. So what's the first step? And so we'll cover a few steps today. Basically, on my screen, if you see, it's the box which is highlighted in dark blue. We are going to talk about data collection, data cleaning, and data analysis. So these three things will basically be the crux of today's discussion. And the intended audience for the discussions and the meetings we are doing can range from a researcher who's junior or even a senior researcher, a data collector, program manager, students, postdocs, pre-docs, funders, policymakers. It's a very, very generic kind of discussion and lecture that I'm going over. Now, let's imagine that you have to now start with data collection. How do you do it? What are the important elements to be? Because even if you have a data collector with you who's had a past experience, say he worked on a polio program or whatever, maybe a national, any national health program, can you get that guy and say, okay, now you start and you help me out with data collection for AMR surveillance? No, you can't, because you have to first have some kind of questionnaires ready. What does he do in the lab? He has to be, trained. So we have to have few documentations ready before that practical bit starts off. So what are those important documents that we actually need when we tell this team of data collectors to go on ground? So one thing which we first and foremost we need is a questionnaire, a data collection questionnaire, which the data collector or the field worker, he will go to the labs and he's going to, pull out the responses from the lab. So you need that questionnaire with certain questions. We'll go on the next slide into details of what should that questionnaire actually contain. We also need to develop a directory of terminologies or a glossary. We'll emphasize later on the importance of this. In fact, the entire surveillance rests on this glossary. And I'll deep dive into that soon. We also need a training manual. A training manual is basically going to be the Bible in the hand of the data collector. So though you may, explain him, but we all know that there is a lot of things are volatile, we forget about it. So the training manual will have all the steps, step 1, 2, step n, how he has to proceed. So these are the three important frameworks which are recommended before the actual data collection happens. Also, it's important that the recruitment of the data collectors, when that's done, it should be in consultation with all the stakeholders. It's very important, and especially the Ministry of Health, if it's at a national level that you're working, so we need them also. So now we're going to get into the data collection questionnaire. My next few slides will be on the data collection questionnaire. So what are we actually looking at? I'll come back always to, what is our objective? Our objective is finding out the AMR problem. And to find the AMR problem, we need to collect the information from different levels. One, of course, would be at the patient level. One would be at a facility level, and there'll be some data we need maybe even at a country level. Now, all this is not etched in stone. It's not essential that everybody has to follow this. So again, this is in general going to create a nice holistic program, but depending on your budget, depending on the scope, your exact objectives, few things may be added above this, or it may be lesser than this. But these three things would really help to create a good surveillance system in any region. So moving to my next slide, we'll now deep dive into the patient level first. So what's most important when you are going to tell the data collector to go to the laboratory and collect information? So his training would be done later. Right now, the work which is happening is basically the work done by the microbiologist who's on the team. He's to first start making, or she or he has to first start making a questionnaire. You know, first he'll make on his own, then he will discuss with rest of the team. They'll all brainstorm. Everybody again adds a lot of value to the draft questionnaire. That's how it happens. In general, we also know that surveillance systems are there. So many a times you don't have to start from scratch. You can see how other surveillance programs are, having the questionnaires. There can be a lot of learning from there. And something else, there could be some nuance that you want to add specifically. So you may like to consider adding that variable also. Now, there is an importance for each of these different points that have been mentioned on the screen. So if you come to, say, the patient's demography, his age, gender, weight, education, for a female patient, even her pregnancy status, for a child, whether the child was prematurely born, the vaccination status, if it's an adult, again, maybe the vaccination. These are different variables which could be used later when the results are all available. Various kinds of permutations and combinations can be done with these demographic variables. So for example, I just want to kind of not show you this as a line list. I want to make you think through, or you can question that, why do we need education level? I mean, what has that to do with AMR? But in the end, when we have the AMR rates available, you can see, was education and the AMR rate having some kind of a correlation? Or in children, you can see, well, if you have the vaccination status in the pediatric age group, does that anyway gets correlated with the amount of AMR that's there in that area or not? So these are just, things which would later create a good evidence. It would again influence your policies, and it would strengthen the information which we already know. Gender also is really important because there are two schools of thought, and of course research always keeps changing. But at certain places we get to hear males are more prone. At certain research studies we get to hear females are more prone. So all this again also depends on the epidemiology of that place. So these variables are really, really important. Now, where will the data collector collect this information from? We also have to keep that in our mind. What's the route he has to follow? So later, when you start training him, where does he go first? Which part of the hospital he goes first? So it could be like any route he can follow, but typically the ideal would be he goes to the laboratory first. Once he goes to the lab, he collects the laboratory information. We'll come to that again. He collects the lab information. Then he sees how many patients are there. He then goes to the clinic. So he can go to the associated hospital, the department. He can go to the pharmacy for the same patient ID. So if suppose there are patient IDs from 1 to 100, then he can track or trace those patients in the clinical side, then maybe in the pharmacy. So he then follows that route. So lab, then the hospital, That means outside the lab and the pharmacy. That route is actually, I think that's an easy route, but again, it depends on this, whatever the project team thinks is most fit for your situation, you can go with that. Now, what about the clinical variables which he would be collecting? Where would that information come from? The best scenario that is possible and which does not usually happen is that everything is under one roof. So he gets demographics also from the labs, he gets clinical information from the lab, he gets the lab data from the lab. That's like, it would be great if that happens, but we know these things really are not recorded in the same place, especially if records are paper-based. So the route the guy has to follow, of course, is across multiple departments. Now, the clinical variables, of course, as the name says, for sure it should be there in the clinical units. So the patient's diagnosis, any complaints he has, comorbidities, what kind of infection if he's had, is it a hospital acquired, community acquired, was he having any device, what about his date of admission, length of stay, his discharge, his final outcome, did he survive, did he succumb? All those things are any existing comorbidities, all that information also is going to be valuable. So this is an ideal situation that if you get info for all this, it's the best thing that we can dream of, because that would really help us to later, as I said, look into predisposing factors and do various kinds of correlation, different kinds of burden, and not simply morbidity or mortality. We can even go beyond that. But in reality, we know it's still challenging to get information for everything. Now, coming to this slide. Now, the lab variables. What are the lab variables? So when the data collector goes to the lab, he has to start collecting certain information. What kind of information he starts collecting? So first thing which he needs to be informed, he needs to be trained, would be about what's the period of interest? Is he going to be looking into, say, we are in 2024 now, are we telling him that you have to collect data from 2023 Jan till, say, mid-June of this year? All that again depends upon the scope of your project. Do you want to go a little retrospective? Do you want to go too much retrospective? Or do you want to start fresh and you say, no, you start from today and go forward? So all these things would depend upon what's the intent of your surveillance program, what do you exactly know, your budget and everything. Now, when he comes to the lab, the place he has to go into a lab, we know, has different sections. It has a biochemistry, it has hematology, it has a microbiology, pathology, but it's a microbiology section he has to actually enter. And over there, he has to request for, we'll talk of all this again, because all these things are interwoven. We'll talk about data collectors training also. So I'm kind of touching it now, I'll touch it again later. So when he goes to the lab, he's supposed to look into the lab records. So let's take this an example that he starts from 1st Jan of last year till middle of this year. So 18-month period. So he's gonna pick up the lab book where all the results are entered. He's gonna start from 1st Jan 2023, and he'll start putting all that information in the device which he's carrying. Now, when I say everything, it is literally everything he should pick up. Unless and until you have some inclusion and exclusion criteria, like you may say, no, we don't want information for samples which are abscess or purulent samples, because they usually are prone to contamination. So you can decide which are the kinds of specimen and sample which are of importance. And but it's always good to, for sure, consider sterile samples because they have the least chance of contamination. So blood, joint fluid, CSF. It's always good to for sure consider that to begin with, but of course, if the budget and everything allows, You can even go pan and just say, okay, just collect information for everything. It's not easy because normally when they go to the lab, it's going to be written everything in a register. So he has to now manually enter, everything one by one into his device, which he's carrying. So this is a really time and labor intensive process. Now, the only thing advantage of this entire thing is that somewhere we have to make a start. It also, highlights the importance of digitization of records. It highlights the importance of having everything electronic. So these things are later at the end of the study, these things get highlighted. And so when we talk about what were the challenges that you had on ground, the first thing a data collector normally comes up is that I could not really, interpret what was written on the paper. It was very tough. There were so many records. I could not understand the handwriting. And that's justified what he's saying. He's telling out of his experience, and it makes then the administration and rest of the team realize, well, that's really critical. We have to invest in electronic records, and it does help in just not surveillance of AMR, but surveillance of any public health problem. We know these things are really required. So coming back to the lab variables, so what exactly, if you just think about, if for example, I go to the hospital and I give a sample for say a urine culture, so what are the things that normally are entered by the nurse or by the person who collects the sample? Of course, my name goes, my demographics go, which I showed on the earlier page, age, gender, all those things are entered. The specimen name, what specimen is it? Is it a urine? Is it a blood? Is it a purulent sample or a fluid, whatever? So the specimen name goes. At times, the site of the specimen also might go, like was supposed an abscess, was it at what location was it? So those things are also there in your data collection being done in the lab when the specimen is being collected. Then the time, they always write on what time did this specimen got collected, what time it was received. Sometimes the collection is at a different place and receiving is at a different place. So those dates are and times are mentioned very clearly. Then which culture is being recommended by the treating physician? Is it going to be a urine routine? Is it a urine culture? So the name of the test. A space is of course left for the final results. So that also would finally be filled in, so the test results. So all these things are variables of interest, and the data collector is supposed to pull out information row by row for each patient on all these different parameters. Most important is we have to specify which bug-drug combination. So bug-drug is basically the pathogen and the antimicrobial. Which combination is of relevance, of interest for your surveillance program? Do you want to kind of cover everything under the roof, or do you want to tell the data collector, okay, don't go for all, I just need for these three important pathogens and antimicrobial combinations? So even that can be, that can also be suggested, or that could be one of your criteria. Now, after the data collector has finished the lab round, he can also go to the pharmacy. He can go in the pharmacy and again check that, okay, for this patient XYZ, could you please tell me, they see the sheet or the records, and then they ask that they want to see what was antimicrobial that was dispensed based on what was prescribed. What was the dose of that antimicrobial duration? So all those things also, they keep getting filled in the data collector's gadget. I also mentioned there are some variables which could be at a facility level. Now, you might wonder, why is that important? Why does the data collector need to go to a facility? But in the end, all these things do influence the resistance that is prevailing. Just like giving an example, and I think all of you would agree, We have two different hospitals. One hospital is having, it's a tertiary high level quality hospital. IPC, infection prevention practices are being followed over there. And another is a remote lab, very in a resource constrained setting. They're not following IPC. It's but natural, it's just logical that you might be having more resistance uh, in a facility which is not very well equipped with IPC paraphernalia, the training and equipment and everything versus the one which is. So again, these are just, you need to do research and find out. It could be just the contrary, but it's good to get information on all these facility level variables. Is the facility owned by a private player? Is it a government facility? Is it affiliated with, say, any NGO or with any other firm? Level of care, is it primary, secondary, tertiary, any co-locations that facility has? All these things are also very relevant when we talk of facility level variables. Even whether the facility has electronic or paper-based records, that's also very important because it also, in the end, you come to know about is it like a facility which is very well equipped with a lot of funding coming through it, or it's a poor facility, not having much of, maybe it's a neglected one in that area. It needs to be now, the infrastructure needs to be further improved. So these variables are important. This is again a list which I have put, does not mean that we can't increase. You can maybe come up with even more thoughts and ideas. And it's always good to have a good big questionnaire, because when the guy is going once to the field, it's good he pulls out all this information. And honestly, pulling out information on the facility level will not take much time, because it's all, I would say it's not more than 1 hour's job, because say he covers even 50 facilities. All this he would just get from the admin department. This is not patient level data, so this should not take much time. And then it's also interesting, if you want to do a large scale surveillance program or study, you can try to get information on how the country is performing on various parameters. So later, maybe, we can talk about certain country level factors being a driver of AMR. For example, physician density. So physician density, if it's less, it's possible that in that country there are some resource crunch and the level of the AMR burden is higher than a country with the opposite. So we should try to get information on all these various parameters. Any questions anybody has?
Glass of water. All right, with the tea.
I'm good. So we proceed. Even the country factors, I would like to also emphasize upon the access to improved drinking water and improved sanitation, because WASH, we know, has a very important role to play in prevention of AMR. So when we even talk of, in general, how do you prevent AMR, and we saw that on the first day, we talked about certain important drivers of AMR, and in that list, we did mention WASH. We did mention poor vaccination. We mentioned about non-compliance to hand hygiene. So we know that those factors, of course, have a role to play. They lead to a greater amount of infection, and hence a greater amount of resistance in the bacteria. So again, all these various factors, variables are important to be also, if you have information on that, it would be great, because in the end, then you can really bring up lots of various kinds of outcomes. Okay. Now we come to the actual training. So I was trying to first, make you just understand how the data collector will move around. What is he supposed to collect from these different sites, the pharmacy, the clinic, the lab, the facility. For the country, of course, he can go online and he can just, do a quick search, and he can mostly get information because those parameters are all in public domain. What's the GDP per capita, WHO, and most of the international organizations, UNICEF, they do have information on all this. So, and you can in fact increase the list of these indicators. So these public health indicators, economic indicators, all that info is available, mostly available. So it can be just, the team could be, somebody in the team can be told, okay, just collect this info, create a database, later we'll need this information. If your study moves on, say, for 3 years, these parameters keep changing mostly every year, so then they can be updated. So what we have done so far, we have created a data collection questionnaire with all the different variables. Now, is that enough? Of course, the next step would be to train the data collector, but is that questionnaire enough? Or do you think that we need something else to complement that questionnaire? We do need something to complement that questionnaire, because what's going to actually happen is, we thought with our best intent that this is just complete, we really don't need more variables. But when the data collector goes to the field, he will not actually get the information in the same way as is mentioned in the questionnaire. He may see a lot of variation in the way things are recorded in the lab. So you need to give him some kind of a long list of terminologies. And his training, when you train the data collector, you have to actually explain him. So after we make the questionnaire, you have to make that glossary. I call it glossary, but yes, you can call it a directory or whatever you want to call it. It's a long list, or a dictionary. It's a dictionary of terminologies. You need that. Why we need it, I'm going to show you some tables on the next few slides on what exactly is this and why is it so relevant. So we need that training, we need that directory and glossary. Okay, so now we are all ready. We have a questionnaire. I have that ready. I have a training manual. I have a directory or glossary ready. So I have these two things ready. And I think it's good to go, and we are ready to recruit the data collector. So you release an advertisement, or you have some previous people who have that experience. But of course, as I said, do consult your stakeholders. Let them know that the data collectors whom we are recruiting for this particular program, this is the group of people. Why is that important? Why am I emphasizing that? Is because once the surveillance study gets over, everybody goes away. And unless and until we leave some kind of capacity behind, or we train somebody to carry it on, all these efforts go waste. So normally what happens is that the ministry guys, or the stakeholders, they recommend that why don't you train somebody who's already working in the ministry, or why don't you train somebody who was positioned over here, because he will stay with us all the time. So hence I'm emphasizing the importance of consulting. Now again, this is a country level program I'm trying to talk about. Of course, if you're doing it at a solitary facility, then that is not relevant. But if it's a large scale study, it will be very relevant to get the data collectors to be those people who are actually working in the government setup or in the ministries. So Right, so we have recruited the data collector, we have our directory and glossary, which I said, we have our questionnaire. Now what next? You need the data collection device. Okay, so does he carry it on some kind of iPad? Where will he enter? He will, of course, not enter from paper to paper. He would be entering from paper to some kind of an electronic device. Is that device configured? You need to configure that device. So whatever were your questions on paper or on your Excel sheet, those need to be transposed that questionnaire gets on your device. So you need to configure your device. And device and a tool are two different terminologies. They might sound similar, but they're not the same. So a device is, for example, if I go to collect data, I take my laptop with me, and that's my device. What's a tool? A tool would be basically, have you kind of installed some software on your computer? Do you have some kind of a program? So that is your tool, Of course, your questionnaire is also a tool, but like WhoNet is a tool. WhoNet is something which can be installed on the laptop, and the information can be entered on WhoNet. So maybe we'll take a short break. That's better. And then we get back. Yeah. So we are back. I hope you had your little tiny break. What all we have talked today? Few things over our page. We said that keep a data collection questionnaire ready. So I'm assuming that's ready. You all have made some kind of a data collection questionnaire. I've given you lots of pointers, what all should be there in that questionnaire, divided into 4 parts. A questionnaire relevant for the lab bit, the facility, the country, from the clinic, and even from the pharmacy. So 5 different parts of your questionnaire. Of course, something would be patient level, so that would be more exhaustive, more time intensive to collect that info. Some kind of information you can just get in a day. So those things are there. Next thing we talked about is create a training manual. Sorry, I've not talked so far. I talked about a directory or glossary. I touched upon it that we need that also as a backup to the questionnaire, and I'll tell you in my next slide what exactly is that. Honestly, in my personal experience, as a surveillance and as a public health person, I thought that was the most important part of doing any surveillance work. It actually is a direction, it's a guidance based on which the data collector actually knows how he has to pull out data from the lab and enter it in his manual. That is the biggest guidance comes from this directory. Without that, 90% of the times, it's not easy to transcribe that information which is on ground to his gadget. Of course, his gadget is basically whatever is available, or in the past, mostly surveillance is not something that's happening only for AMR. It's happening across various other areas, disease areas. So these gadgets are always there. It could be an iPad, something, a palm holding device, a mini laptop. So that is there. It needs to be configured, and then it has to be having that specific software. It could be a software which is already, like WhoNet is an app. It's very popular, hence I'm talking about it. It's a freely available software. It can be downloaded, and recently it's also been advanced to a very high level. We'll talk about WhoNet soon. So that is one of the softwares, but having said that, not everybody would maybe be using it. So you can have your own analytical software, your own tool you want to put on your laptop. And now your data collector is there. He has to start his training. How will you start his training? Of course, you need, now this is a different topic altogether, training of data collectors. It's just like arranging a workshop. You have to have an agenda. You have to you have to send invitations to even the stakeholders, because they would like to come and see that because training also needs to be financially, it has to be the money has to go for training. So you have to tell your funder that X amount of the money is going to go in training. So somebody from the funding organization usually likes to, come over and seeing how you are conducting the training. So make a long list of all the people who are influential, who are important, who are critical, and they should be also invited in this training forum. They may not necessarily be receiving the training, but it's good to get their their support, their leadership on that day of training. So you can have the Minister of Health, you can have some high level government official to come and do the opening remarks. So you need those guys also on the day of the training. Whom else would you be calling? You'll be having a trainer, the master trainer. So master trainer is the guy who actually knows everything. He knows the IT systems. He knows what are the questionnaires like. He knows everything. So he sits closely with the microbiologist when the questionnaire was made. The microbiologist explains to this master trainer all the technical bit, all about the data variables, all about the options and glossary. So this guy is like uh, he's the central guy. So as I said, everybody has a role in a surveillance program. Everybody is important in different ways. Now, he also is knowledgeable about the IT systems, because in the end, all this information enters into the data collector is going to put it into a tool, into a device. So he needs to be trained, the data collector. He may not be that knowledgeable. So it's the duty of the master trainer to explain, and it could be a 2 days training, it could be a 5 days training. Usually it's about a 4 to 5 days training. You do some exercises, you explain them, give them some dummy exercises to do. Also, in this training, you take the data collector. In fact, I had wanted to do that, a little bit of a run, even in this 5 day course here, but it is not feasible. But the data collector has to be told during the training time. You take him to the lab, you take him to the hospital, you make him, get the feel and the pulse of what exactly he's supposed to do. So it's like a mock show that he and his team. So there'll not be one data collector. You might be having about 20 of them, depending on how big is your study, or you could be just having 2, 3 of them. So these guys, they should be doing a mock drill, take them to the lab where actually you'll be collecting the data, take them to different kinds of labs. Say you're doing at a regional level, a big surveillance program, and you have chosen one particular country as your venue for the training. So you can, plan the theory classes, and then in the practical, you can take the team to a primary care center where there's a smaller lab, and even to a tertiary hospital where there's a bigger lab. So they kind of understand, because all these different places have different ways of storing data. They have different kinds of laboratories. So it's good for them to kind of, walk together with the master trainer during this training phase. The chief microbiologist must be also there on that day, because there'll be lots of brainstorming, questions, answers. So it's good for everyone to be together over there on that day. Okay, so I was emphasizing time and again about the glossary. So I want to, this is just uh, like it's a bird's eye view. It's not exhaustive, but whenever you make a surveillance or you plan a surveillance study or a program, you need this kind of a directory or a glossary. What is the purpose? The purpose is basically, as I said, your questionnaire may be anything, but in reality, you will not get it's something like you're cooking a dish and your mom's given you, the ingredients, but when you go to the market, you will not get the same ingredients. You might get some kind of a a different variety. So is it the same? Can it be considered identical? Can it be used as a proxy or not? So this is what the data collector does. He has to be given this. So if you see on this chart, let me explain you. You see three columns. Again, this is based on my experience as I have created the glossaries in my prior work. So you already know what is the variables of interest. We saw that when I showed you the variables which need to be collected from the lab, from facility, blah, blah. So when you collect it from the lab or from the clinic, we talked about gender, for example, as an important variable. Now, when you go in real world, what's going to be entered against the patient's information would be, of course, female or male, very simple. So gender is the variable name which we had seen in my prior sheet I had shown over there. So gender is the variable name. As an example, we'll just talk of gender for now, and then we'll talk of others. So there are two options that can be there, right? Now you come to the middle column. The middle column is the code. So code is a standardized way that we will be writing the variable name. So the name in the questionnaire was gender, but the name in your glossary would be a little bit of a modification. Here it looks the same, I've just capitalized it. But if you look, for example, specimen name was also in my questionnaire. But when I'm trying to code it out, I'm writing spec underscore code. So that is an abbreviation for this particular variable name. So every variable which is there in the questionnaire, ideally it should be represented to a variable code. So it's basically nothing, just rephrasing that into some kind of a standard entry that is usually done. Now, why are we basically doing this is because you will also see we would be doing it for the various options. For example, for specimen, that you can have thousands of specimens, right, in the lab. You could have blood, urine, fluid, CSF, XYZ. So when you go to one hospital, that blood may not be always written as blood. Okay, it could be bloody specimen, it could be bloody fluid, or it could be anything, so it may not be written the same semantics. But when the data collector, he starts copying exactly the way it's written in the lab record, he'll have millions of different terminologies for that one specimen. So we need to standardize that. So that's where we're trying to put a code. So we'll explain him that, look, if you see anything like urinary sample, or anything like that, write UR. So all those 5-10 different variations of urine specimen would be entered as urine. Joint fluid, or intra osseous fluid, anything which is like about all pertaining to the joint fluid, write it as JF. So this is the way you're going to standardize all the different variable names to a variable code. Likewise, even for the organism, for example, it's Acinetobacter baumannii. Somewhere it may not be written exactly like this. Maybe in one lab, you might see it written as A. baumannii, or it could be Acineto baumannii. Or so, what would he write if he starts writing all the multiple versions in his tool? It would be like really, everything would get so complicated. So we have to actually have this glossary, which is going to have this middle column, which will be the standardized entry. We call it the variable code. So every option is going to be put into a code form. And also, we should give a numeric code to each of this. So for example, you see Acinetobacter baumannii, second last row. We have put a variable code, which is ABA. That's the English version, but then we put it into the mathematical version, we put 21. So we also try to give a numeric code to all this. All this actually helps when analysis is being done. So, but at this point of time, when the data collector is on the ground, he needs to be very, so the glossary has to be in his hand all the time. It definitely helps us, the analytical team later, to do all different kinds of cleaning, analysis. It takes time in the beginning for the data collector, but then they get so used to it, they really exactly know, you know what, if that's there, please put this, please put that. So it makes life really simple. So the purpose of your glossary or directory is converting all the raw entries into a standardized information. What I'm showing you is a tip of the iceberg. These glossaries are really huge. They run into almost 40, 50 pages for all the different variables, for all the different bacteria. I've just shown you two over here, but the list of bacteria is huge. So for every bacteria and organism and a code. Now, you'll ask me, that's huge. How can we do that? Of course it is. But well, if you have to find out, some concrete outcome, you have to do that exercise. Is there an easy way? Yes, there are easy ways. There are already some existing directories and glossaries. You can consult them. Anything that is in public domain, yes. Net is again there. I'm not trying to propagate anything, but I'm just giving you an example that those things are really handy. It does help. They have a long list of all the bacteria. It can be checked. And of course, again, the project team can decide whether they want to, create their own, and they can explore. But this is really integral to a training program, and finally the subsequent steps. Now, I also want to emphasize over here about the lab ID and patient ID. These are two terminologies which are totally different. Now, in some hospital, they may mean something which may not be the meaning in a different hospital. So we have to basically be very careful about what is the meaning being used in the hospital, and then convert it to some kind of a standard. For example, a lab ID may mean sample number in one hospital, but in another, it may just mean the identification number of that particular laboratory. So be very careful when the data collector is being trained. This thing needs to be emphasized. It's not that a lab ID written in one lab may have the same meaning as a lab ID written in another lab. These things can later, it can create some kind of complication during analysis, because one data collector may say that, I wrote lab ID and that was the meaning. Other guy might say, no, but in my lab, they used to write lab ID for this particular meaning. So we have to also focus on the exact usage, how that particular lab is using these terminologies. Even patient ID. In some places, lab ID, patient ID mean just the same, but in some it may not be. So we have to train our data collector. These two things are really critical, both the lab ID and patient ID. They need to be very clearly understood by the data collector, and then accordingly the actual code has to be put. Then we talked about QNet, not going into detail, but just want to tell you it's a tool for data collection also. It's a free desktop Windows application. It can be used for data collection, data analysis, both. Sometimes you may say, okay, I'll use it for only data collection. I don't want to use it for data analysis. That's up to the organization. But it's standard. It helps in AMR surveillance, well supported by the WHO Collaborative Center also. And recently, it also has the breakpoints for CLSI and UCAST 2024, both human and animals. So if you want to do animal surveillance, of course, that can also be considered always getting updated every year. So it can always be looked into just for understanding when I'm talking about the glossaries. When you see that, you really understand how detailed, glossary we should be creating. So we're going to now come to the actual data collection. So up till now, what we have done, we have even finished the data collector's training. He's been trained on everything. He has his glossary. He understood what does a glossary mean. He was taken to the laboratories. They did their mock drill. They understood about how the data collection device, how is it switched on, how is it switched off. When they went to the lab, they did some dummy exercises. So you kind of got him confident enough to finally be left alone and start collecting the data. So say, for example, from tomorrow, your data collector is supposed to start collecting the data. So what's the first thing he should do? In fact, prior to his even going to the lab, his supervisor should be calling up the head of the labs and letting them know that, well, tomorrow my boy is going to be there at this XYZ time. And all those kinds of formalities have to be completed by the supervisor of that particular data collector. So you need to have somebody supervising the data collector. It could be the master trainer. I mean, these delegations of roles has to be decided internally, but it's always good and courteous that instead of the data collectors walking in straight and start collecting the data, nobody would let him enter. So you need to again, create another code of interaction and getting these kinds of formal approvals for this boy to go tomorrow and start collecting data. Having said that, don't forget, we also talked about the data sharing agreement, which was already signed off earlier. So that letter also is always handy. The data collector needs a letter of introduction. He has to carry that. It has to be issued by the responsible person. It could be the project lead. It should also be signed off by one of the top stakeholders, maybe the funder. The Ministry of Health person, of course, is also very important to sign off these kinds of letters. Again, all this depends upon, I'm talking of a scenario where you really have to work at a country level, but few things, maybe it's not relevant in certain scopes, but in general, it's ideal to kind of cover all these things. The route to be followed, he has to know, and we talked about it. Ideally, he should go to the lab first, or he can even decide, okay, I'm not going to the lab, I'll go to facility, I'll collect the question, finish the easy questions first from the facility and about the country, if that's also there in your questionnaire. And then he goes to the lab the next day. He might take 4 or 5 days in the lab, he might take 2 days. And also, you should have some kind of backup plan in case there's an emergency, things are shut down, there's a pandemic, what happens? I mean, everything gets stalled. So you need to keep those kinds of things also into mind, that there could be some unforeseen circumstances, an earthquake or whatever. So the whole thing gets stalled. So we have to also keep those emergency situations in mind, which might delay certain processes if not already done. So the route we just discussed. After the lab, he goes to the clinic and then he goes to the pharmacy. So when I was on a tea break right now, one of you was asking me that, well, how can the data collector go to the clinic? Because and that's such a interesting thought, that actually is not very easy, because if in the lab he gets the names of all those patients and he gets their patient ID, he can only go to the clinic to get the clinical information if the same ID is being put in the clinical records. If there's a completely different number that he gets in the clinic, you cannot track and trace this patient. So you just have his lab info, but you're unable to collect his clinic information because of lack of that, consistent number. The numbers have changed. It might happen, and it is quite common. Again, these are challenges which we now discuss on the last day. In general, what are the issues that normally happen? Of course, it does happen in low middle income countries. It may even happen in high income. It may not happen in low middle income. So, I mean, but these are the things that are generally seen in hospitals, and we all know we work in healthcare. These things are they may just happen. So, yeah, so in that case, he cannot go to the clinic. And then his work stops at the lab. He reports back to the project officer and he says, well, sir, I did the lab bit, it's done, it took me 10 days, but there is no way I can go to the clinic. The numbers are totally different. I'm sorry, we have to stall. For this hospital, it's not possible. But maybe for some other hospital it is. So this has to be, you'll just assess it hospital to hospital basis when the data collection happens. And best case scenario, of course, would be the numbers are consistent. So from the lab, you go to the hospital, everything is seamless, everything is electronic. Even in the lab records, maybe you have the clinical history mentioned, so you don't even need to go to the clinic. You have all the information out there. You just see, okay, well, on the lab record, you see, okay, he's a case of dialysis, he's a case of chronic kidney disease, and every information is there. So he may not even need to go there if he's getting all the answers from the lab. Or not as good scenario, but maybe still a good one is that the numbers are there, so the patient can be tracked from the lab to the clinic. The data collector goes to the clinic. Everything is electronic. It's easy for him, to get. So there are also ways in which, if records are electronic, they can be easily linked to the data collection tool. So there are ways to do that for these pharmaceutical companies and diagnostic companies. When they install a testing device in your lab, it always has that kind of linkage. So all the data which is there in your machine, in the lab machine, it gets interlinked to the data collector's gadget. And there are ways, the IT guys are, they have a know-how about that, and they can guide. So this electronic records, if that's there, it can be easily synced. But again, how many labs actually are having that only once you go on ground do you come to know. Now, what about data storage? Data storage, ideally, it should be done automatically on the device. We do not want that the poor guy has entered everything and then it's not automatically getting saved. So the best thing is that these things have to be considered from before, and the device should be configured in such a way that the data is saved instantly. And it is possible that he doesn't have a network, but there should be a backup provision that the moment he gets a network or he goes to the office or wherever, it is immediately synced with another server. So all this information on his gadget, it goes to the cloud or it goes to the server where it's supposed to go. Again, all these things are very clearly and should be clearly defined in the data sharing agreement. It's always good and recommended that before the data leaves the lab, it's encrypted immediately. So there is no breach, no information, private information is leaked out. It stays right there and it's encrypted at the time the data collector is entering the information from the records in the lab to his device. Automatically everything gets encrypted. It's also very important for the supervisor or the master trainer to do random visits when his data collector is on the ground, just to be sure that things are moving the way they are supposed to. It also gives a sense of we can't just let the data collectors be totally free, and so somebody has to keep monitoring their activities. So we need the supervisory visits, and also perhaps it's always good for supervisor to be on the ground and then do some kind of troubleshooting, which the data collector cannot do on his own. I missed a point, and that is that at the time of training, the troubleshooting part is really explained very well to the data collector, because if we are all talking about his doing transcribing information from the paper records to his machine. And we know systems can fail, or sometimes it just stalls. So these troubleshooting things at times they're easy to solve, at times they may not be, so then they have to be escalated. But most of the troubleshooting things that can be thought of, they should be entered, they should be written in the training manual, and the data collector must be aware of each of those points. Certain questions need to be answered before, in fact, at the time the project has been conceived. What are our timelines? How much, how do you decide that? It depends on the amount of money that you have for that particular program. If it's a standalone hospital, there are no timelines. It could be done for till eternity. But if it's a funded program, resources may be limited. You may say, okay, it's a 3-year study or it's a 1-year study, and then the systems will be developed, and then they'll be sustained later internally, however. So we need to also have clarity on what is our date of start, date of end of data collection, plus minus a margin. Also, how many records should be collected? I mean, are you expecting data collected to actually go over those 3 years records and everything is on paper? Is it feasible? I mean, it's not. We know it's not. So do we kind of give some kind of random number? Okay, you just collect 5,000 records, or do we? So again, the different schools of thought. Who decides this? Basically, the project team sits together. You should have an epidemiologist on the team. He can also, give some kind of guidance. Sometimes actually you just need to come to a middle path, and whatever works best should be done. Best scenario is collect everything. That's of course very challenging. So you can say, okay, maybe, I mean, I'm just giving ideas how things have happened in general, and they happen across projects, is that you can say, okay, we'll do it at every, say, 3 monthly intervals. So for 1 month you collect all the data, then don't do it for the next 2 months, and again the 3rd month, 4th month you do all the data. That is one option. Or you say, okay, bi-yearly, but all the data for that 1 month. Or you want to say, no, for 4 months comes constantly. So again, or you can say every week you do it and then take a break for 5 weeks. So again, these are various ways. It has to be done in consultation with everybody on the team, guided by, of course, the statistician, the epidemiologist, and of course also agreed upon by the other strategic partners who are there in your stakeholders, the ministry. It should be agreed upon in the beginning, because in the end, when the project is closing, there should not be any kind of a confusion, and things should be very transparent, agreed upon on day one about these challenges and then what to be done. Okay. So I'm just wondering if anybody wants to take a short break, or do we continue? Okay. We continue?
As you wish.
So we continue. Now, the next step is going to be that the data has been collected, it's been uploaded by the data collector. So his work stops here. He's finished his job. His work was to be going to these various areas, collecting the data, and his work is done. Of course, he stands by. Maybe he needs to re-clarify something, but he would be told about that eventually. Now, once he's uploaded this data to the server, to the cloud, whatever, somebody on the other end is going to download that data and then start processing. Now that job is done by the data reviewer. I'm calling it the reviewer for me because I feel that's the easiest way I can explain. But again, these are just terminologies. Maybe in some program, you might say it's a data manager, somebody might say it's our data, some officer or anything. But for the sake of the training I'm giving, I'll use the word data reviewer. So now the data reviewer downloads all this data. How does that data look like to him when he downloads it? Typically, the data would look something like this. Okay. Now, if you see it very closely, every row is a patient. So I'm only showing the patient level data. I'm not showing facility level information or the country level. I don't think that's really required. We all know how it would look like. That's just a single page. But this is like huge. Again, depending on the scope of your project. So every row is a patient information, and you can have the laboratory number. All these should be obviously de-identified. You know, we should not show the names of the labs. Then the labs, you have, as I mentioned, a lab ID, a patient ID. These are just kind of identifiers to be able to, tomorrow, if required for some reason, we need to kind of go back to the data collector and tell him, you know what, double check this information. This doesn't make sense. So till there, we of course need some kind of information about the patient to track. So those are the tracking numbers. His gender is there, his date of birth, age, department. So this is how it looks like. So the first few columns, as you can see, are more around the demographic and a bit about the clinical information, so the diagnosis. It's more around the demographic and clinical. The next part of this chart, as you can see, is the patient's lab information. If you remember, the data collector also collected information on 3 different kinds of variables. It was demographic, it was clinic, and it was the lab. So you also see the lab information there. The urine samples, somehow I think we just are showing you the urine right now, but that's the way you can put the filters. Later, when you want to do some kind of a summarization, you can say, okay, we had X number of urine samples over this period of time, so that's how it's being put. A specimen code, I mentioned to the group that every specimen should be then reworded, recategorized into a type and a code. It just helps in analysis at a later stage, because otherwise you will have millions of ways you can call the same sample. So we want to reduce that redundancy, and we try to give both a nomenclature and mathematical coding. Then organism names will show wherever it has grown. If it's not grown, it will not show. And then you can see from in the last 6 columns, you can see the antibiotics for those patients where bacteria grew, and then the susceptibility testing was done for the antimicrobials. Information was available in the lab records. The data collector entered. You can also see that somewhere numbers are there. So that's a zone of inhibition. Somewhere you may not get the numbers. The lab records are like resistant, intermediate, sensitive, RIS. So RIS would be out here. So this is the raw data in front of you right now. Just an example to show you how it actually looks like. And it's also important to point out that where the lab and hospital issued, and I just mentioned that a while back, where the lab and hospital issued ID is the same. Of course, you can keep tracking that patient from one part of the hospital, that's the lab, to the clinic. And even if that patient comes multiple times, you will know the same patient has come again. But if that hospital gives a new number to the patient each time the patient is coming to the hospital, you just can't do anything about it. That patient would be counted multiple times. And of course, this does affect the analysis in the end because there will be a lot of bias. So we have to understand, and that was the reason why I talked about the facility level questionnaire. We need to have that kind of even a chat with the hospital in charge. How do you give IDs to your patient every time he comes? Do you have the same ID for the lab visit and for the clinic visit? Are they different? So that needs to be, you have to speak with because the data collector may not be able to do this. So a senior level person can get answers to this if required. Okay, so now, what is the data reviewer going to do? Right now what I'm showing is what he got on his chart. So I'm the data reviewer, for example, and you say Louis collected the data and he gave it to me. And he says, Geeta, now you check this for me. So I'm here, I see this data and I start reviewing it. How do I review this data? So let's talk about that. Again, I'll tell you in brief. What are the steps that I will actually look at? I will look at whether is it complete, is something missing. For example, it's possible that on this particular sheet, the specimen type is not mentioned. Okay, so honestly, if a specimen type is not there, I really can't do anything about it. This will be filtered out. I will max to max, I can ask the data collector to go back and check why is it missing. But if there is just it's not there in the lab records, it's thrown out. That data, you can't analyze it. There are many variables which are mandatory. So you can also, specify that this is essential for analysis. For example, the name of the specimen for sure is essential. We know that. Another thing that would be essential is the date the sample is collected. It's important because, if you don't have the date, it could be challenging. It could be a data from a different period of time. How do you kind of be sure it's for the period for which you are interested in collecting the data? So it validates the time of data collection. It falls in your inclusion criteria from, say, we said it was 1st Jan 23 to 30th of June 2024. If there is no date of specimen collection, it could be possible it's not in that period, right? Even if it's in the lab record, but we have no evidence, so we have to throw that data out. So we need to see completeness that every cell is filled out. You also need to see that wherever the bacteria has grown, so I'm going back here, if the bacteria has grown, do you have the AST results? If there are no AST results, but the organism is there, it doesn't help us because what we are going to actually look at is the AST result. Based on that, are we going to calculate the AMR rates? So if somebody tells me, oh, we have lots of bacteria, and I say, okay, sure, show me the information, but they don't have AST result, it means they're not testing for AST. So all that is waste for us. So again, that's a very important information. Many a times it does happen, and I know, I'm a microbiologist, I've worked in labs, and my experience is that at times, the team may not be experienced, the junior teams are checking, they may just write down gram-negative bacteria, and they still go ahead and do a AST testing. That doesn't make sense, right? Because you say gram-negative, but like gram-negative is not name of a bug. So you need to know what kind of information will be totally non-helpful in analysis, or they may have candida and they may be checking it for, say, against antibiotic. Now that's a total mismatch. So this is the time when we are reviewing the data, we have to check that everything is making perfect sense, the right antibiotic tested for the right kind of a bug. You can't, for example, check E. coli for vancomycin we know vancomycin is for gram positives and it doesn't work on gram negatives. So those kinds of, data checks have to be done. That's the meaning of data review. Some people call it data check, some call it data cleaning. Some people may have different meaning for these terms. Again, I leave that for the project team to decide. But these things are essential. Now, when you're checking the data, how do you, somebody on the team needs to be very familiar with the CLSI and UCAST guidelines. Again, depending on what guideline is being followed in that particular hospital or region or country. So again, the role of a microbiologist, technician, or a physician is important because they can then, help the data reviewer when he's reviewing. He may not know these little nuances, which bug, which drug, what's the ideal disk. For example, for certain bug drug combinations, they say you can't test with, say, 10 microgram or 30 microgram of disk, or you can't do MIC, or you can do MIC and you can't do the disk. So these little nuances, who is knowledgeable about that? Of course, a person working in the lab is knowledgeable. So you should have inputs from that person. Maybe some expert can guide you if it's not internally in the team. There can be some expert guidance you can seek at the time of data reviewing, because it's very important that in the end, when we move to the step of analysis, we are sure that our data is reviewed well, all the junk is out, we are not analyzing any information which is erroneous, because all that would then totally affect our result. Now, it also happens many a times certain things may not strike us. So when we are making a glossary, it is possible that the data collector actually comes up and says, I did not find this in the glossary, but when I was collecting the data, I found this entry. And then you need to include it in your glossary. So there are, of course, things do evolve with time. We do try that glossaries as replete and complete as much as possible before the start. Having said that, there is always a room for improvement, because on ground in real life, when things are getting picked up, new things might need to get tweaked and added, and that's like for every study, for every project, that does happen. So the data collector might flag about this, new entries, that I'm seeing these new kinds of entries, it's not there in the glossary, so then they need to be included. Also, it's very important to tell the data collector that, because again, when you do the analysis, you'll be following a particular format. So the date of entry is again something really important. How it needs to be entered, because if the data collector enters it in different ways on different days, it's going to be very messy. So you have to tell him to be very consistent, that please put the data entry, and you can decide that beforehand that, okay, it should be DDMMYY or MMDDYY or whatever, but please do not deviate from this standard. So this has to be a protocol. It's the team which actually analyzes. For them, this is really critical. And again, at the point of reviewing the data, we need to look into all these nitty-gritties. Now, you'll ask me that, how can you manually check data which is so much? We don't really check it manually. We can eyeball manually. Normally, somebody in the team, as I had mentioned yesterday, who's good with programming, they create scripts. So they can make those kind of scripts which where you feed in all this information, and then that reviews this large scale data, and it immediately can tell, okay, this was wrong here and this was missing here. So that is the way it can happen quickly over these large volumes of data. Okay, so at the end of data review, what have we achieved? We have achieved two important things. One important thing is that the AST results, which would come finally to the data analyst for analysis. It is going to be validated. It would be totally checked, and there will be no mistakes out there. And the other important thing that would be checked for in data review would be the data is all complete, it's accurate, there is no redundancy, there is no overcounting. We will talk of overcounting also in the subsequent slides. Okay, so this is the second part of data review. We are still not finished the data review. Few more things to add. I kind of covered it, but I'm giving you some specific examples also. When you are looking into the AST, antimicrobial susceptibility testing AST entries, you need to be sure, and I did talk about that, the tests that are being considered for analysis. So the reviewer kinds of agrees, okay, this is fine, and they're good to go for analysis. They are only for the valid tests. So I did mention that you need the microbiologist guidance. If you don't have in-house, you would need to have an expert on board. And some random examples, which often you'll see are mentioned out here. E. coli with vancomycin, we know this is inappropriate, invalid drug. So there could be different ways that things are invalid. One, organism antibiotic combination is invalid, or the combination may be valid, but the testing method is invalid. So we'll talk of that. E. coli and vancomycin, it's a case of inappropriate, invalid drug, because we know E. coli is intrinsically resistant to vancomycin. Hence, there are no breakpoints for interpretation in any guidance, neither in UCAS, neither in CLSI. Another example is Streptococcus pneumoniae with penicillin disc. Again, it's the drug is appropriate. However, this diffusion, so it's written disc out there, this diffusion method is not reliable. So you'll never have breakpoints. Ideally, it should be tested either by penicillin MIC or by oxacillin test. So all this is actually mentioned in the guidance documents. Third, enterobacterials with oxacillin, same as what was written on the top, E. coli with vanco. It's not a valid antibiotic. Enterococcus with oxacillin, again the same, not a valid antibiotic. Staph aureus with oxacillin disc is again not valid. You should use the cefoxitin discs. So these are, a few very commonly noted issues you might see in your when you're doing your data review. Also, sometimes people might disagree with CLSI or UCAS breakpoints, and they may have some other breakpoints in mind. So in this case, they should manually, put the breakpoints in their tool. But this is really only for scope of those who are aware of official recommendations. CLSI, as an example, has no breakpoints for tigecycline. FDA has, so some labs may have to put those kinds of breakpoints. So I would leave, this decision making in the hands of the expert microbiologist, because this is really important before we move to the stage of data analysis. And now we are coming to, we have about a few more slides left, but the data review bit is near completion. So what do you do when your review is complete? You're still not analyzed anything. You're just still cleaning the data, reviewing it. You're doing your litmus test. and it's done. So what next? You should summarize all these review findings. This is very descriptive. You can have some kind of, presentations or charts. It's so important. And we emphasized that yesterday and day before, to share these findings with your stakeholders on timely basis. Even if you haven't achieved, you've not come to the stage of data analysis, even then, whatever you've done so far, it should be discussed with your funder, it should be discussed with your with the ministry, with other stakeholders, other partners. Always good to disseminate whatever has happened so far. You never know, you might just get some good pointers from somebody and it might improve the quality of your exercise. So end of the review, you can talk about how many cultures were available, total, how many were positive, how many were negative, how many were contaminated, how many grew commensals. Again, you can split your cultures into how many urine, how many blood. So you can do those kinds of permutations, combinations. How many positive cultures had AST, how many positive did not have AST, or how many positive were having a full identification of the bacteria and so genus and the species, or how many were just having, like just Staphylococcus was mentioned and species was not mentioned. So a generic level identification, or was it a species level identification? So all that info you can very clearly get once your review is done and the data is all clean. It's very important to kind of get that kind of info. And now, once your data is all reviewed, you've summarized, you move to the next step, which is data analysis. How do you analyze this data? Okay, so we are just going to rewind our memory and we're going to think about the various variables of interest we had put when we were collecting the patient information from the lab. All that is now going to help us in this part of data analysis. So what are we looking at? What was our project scope, or what was the scope of surveillance? It was to estimate AMR. We're keeping it very simple. We're not going hi-fi. We're talking of just the rate estimation or the resistance. What's the resistance in this group that we have? We are collecting the data on. So how do you define resistance rate? It is basically a proportion. Proportion non-susceptible. So when we say non-susceptible, we all know it includes both intermediate and resistant. We don't use the word resistant, so we use the word non-susceptible. That's as per standard definitions. And we are trying to see to what extent is this pathogen resistant to a particular antimicrobial agent or class. Always good to kind of combine data for different agents and represent it in the end for at a class level. It makes life much easier. Now, when you are analyzing the data, the only part is that you have no control on the data that has been submitted to, that has been collected by you. You never tested it, right? It was tested by the lab. So you have no control. So please always put a disclaimer that the data analysis has been done as per resistance interpretation submitted by the lab, because we have no control on that. We are just kind of program officers, or we are doing the surveillance. We're surveillance too. Having said that, it's also important, for example, if this data was collected for last year and we are analyzing it this year, so we should adjust the values as per the current recommendations. Now, what do I mean is that, for example, the AST result says resistance to some combination, and the zone of inhibition is 18. But as per the most recent guidelines of CLSI or UCAS, whichever the lab is following, if that 17 now falls in, say, a different category, it's no more resistant, it's sensitive, or if it was sensitive earlier, it's resistant, that number 17. So we can overrule the RIS which the lab had put in its records, because we will be adjusting the interpretation as per the most updated breakpoints available by the guidance. So this is very important, and I would like to emphasize this. Wherever the labs have provided quantitative results, this can only happen if you have quantitative results. Means either you have the diameter measurements or you have the MIC measurements, then can you do it. If you didn't have that, if you have it in qualitative format, in RIS, you can't. But if you have in quanti format, you need to adjust this based on the most updated breakpoints. So as an example, if you're analyzing 2021 data today, you're supposed to use the 2024 breakpoints. You only use 2021 breakpoints during the year 2021. After the year is over, you should use the newer breakpoints even if the data are older. The reason is that the breakpoints change because they believe that the new breakpoints are more accurate. This diffusion test itself has not changed, but the experts' understanding of what is resistant and susceptible has changed. So if you're analyzing data from 1990, 2000, 2010, 20 to now, you will be using the current breakpoints. This is the official recommendation from CLSI M39 document, and I have that as a reference over here. So good to know these recommendations which are there by experts. So we should keep that into consideration. Now, another very important thing is that when you're analyzing data, as we were discussing, it's all historical. And we also know, I myself, when I was in my lab, I mean, I honestly never used to write down numbers. I used to see, okay, I used to eyeball, yeah, this is resistant, this is sensitive. That was experience. So, we get so overconfident, we write like that. But it's always good to always put the quantification, the zone, or the MIC. So again, the reason is because tomorrow this data which I am writing today may get interpreted after 10 years. So it is important to just not eyeball, but to put these actual numbers for future analysis. So this is something which I wanted to emphasize. And I already mentioned that try to collate the data for different antibiotics and present it at a class level. So if you have gentamicin, amikamycin, streptomycin, best is to have it at a class level, which is aminoglycosides, and likewise for other. It just is much easier in the long run. Now, again, this part is a little bit, tricky when you're doing analysis. So just the very important things, it's important for all of you to know, because the whole idea is we're talking of AMR surveillance. So these are the technicalities which you as experts have to know. The duplicates must be removed. We should not double count a patient. You can only do that if you have the patient ID, right? I cannot remove a duplicate if that patient is getting a new ID every time. Then it's beyond our control. But if it's within our control, we're getting it's clear that it's the same patient coming multiple times. Of course, remove his subsequent results. Now, what do you remove? Now, the recommendation says, this is as per CLSI M39A4 guideline, include only the first isolate of a specimen of a species per patient per analysis period, irrespective of the AST profile. It could be sensitive, it could be resistant, irrespective of the body site, but the first species which gets isolated for that patient. So if that patient has sent multiple samples over the last, say, 6 months, the first time that his isolate was the bacteria was isolated from that patient, be it from any site, but the first time it came, that needs to be noted, even if it was sensitive. It's not essential that you have to pick up the first resistance sample. But this is a recommendation mentioned in this guidance, hence I'm mentioning. So you don't have to take subsequent samples of that patient. Also, there is no need to present statistics on every drug tested, especially when you are combining data from different labs. What you can do is you can basically talk of the more common ones, and whatever is like clinically relevant, those can be taken. Because if you start analyzing for all the drugs, of course, it's going to be a lot of so those little nuances may be considered. So that means that analyze for a broad set of recommended usual antibiotics and try to get those to be as complete as possible. Another recommendation is that analyze the data only when you have 30 or more isolates tested against an antibiotic. So if you've less, it doesn't make much sense because it would be too little a figure. So they have given a cutoff of 30. Again, the same guidance, CLSI 39A4. And so we go with this unless these guidance changes in the future. But as of now, this is what is there. And always carefully state all the limitations. In fact, the best way is that from day one of the project, we should start writing it down. And towards the end, we know that we have included all these various limitations, which of course we will be talking on the second last and the last year once again. In general, so over the last 3 days, we have alluded to various challenges and limitations. We put that together, but we must note it throughout our program period. Okay, so I'm just double checking if you're all good, or do we take a 10 minutes break? Whatever.
Nope.
Yeah.
Maybe a quick break.
Yeah, great.
Okay, great. Perfect.
Maybe for 10 minutes, resume 5 minutes past the hour.
Yep.
Okay, so we are back, and now we talk about the data analysis is done. You know how to do it. At the back end, there is, you kind of program your machinery on what is important, what is not important, what's filtered out. Based on all these rules, there could be more, but these are the very important ones which really help you in analysis. There could be a few more that you can take a call if you want to kind of tweak something. But I recommend, since you're talking about AMR, do please consult your most recent Clinical and Lab Standards Institute guidance document for the latest year for aerobic bacteria. When you're analyzing aerobic bacteria, so you know CLSI has different kinds of documents. CLSI could be talking of aerobic or facultative anaerobic. It could be talking about simply the analysis and presentation of cumulative AST test data. So CLSI has different kinds of it. There is a separate book on the Clostridium, separate one on fungus. So you have to be sure of which book are you picking. We are basically talking about surveillance of normal bacteria, the aerobics, so aerobes. So we have to pick up with that guidance document. That's the M100. The M39A4, which I've been quoting throughout, that's more to do for your analysis and presentation of the AST test data. So all these suggestions and recommendations which we have discussed are coming from the M39A4. M100 is the breakpoints for all these bug drugs. So that's there. But of course, if you're in a region which follows UCAST, then the UCAST guidance should be read through. It's really important because you cannot analyze until and unless the data which you have reviewed is being reviewed well, and you can't review something till you have that guidance. So we need to have an expert always on board who's very familiar with these guidance and can guide the guy who's reviewing the data on how to. So again, the teamwork is very important. You need to have a team with every person coming up with a different kind of role on execution of this kind of exercise. Now, this is very simple. I'm just trying to, simplify. I don't want to complicate. Of course, graphs can be really innovative. We leave that for the project leads to decide. This is very simple. You have two labs, and you have, 4 different bugs tested against 4 different drugs. What kind of resistance non-susceptibility is being seen. So these are random numbers that you see on the screen. And then, of course, as I said, you can have different kinds of graphs, and that can be portrayed like that. So again, if you have more labs, you'll be having more such clusters. You could be doing at a country level, not necessarily at a lab level. So that's the way you can depict. You can also have time series. So it could be not at one point of time, but it could be a trend line that is there. So all these are the different kinds you can do your graphical presentations. Now, just want to emphasize upon the confidence interval for the AMR estimate. So normally we have that 95% confidence interval, which is mentioned against the main estimate. And traditionally, so there's nothing wrong or right in this, but just kind of want to share about the traditional way we normally calculate the confidence interval is at the 95% confidence level to quantify the uncertainty in this estimated resistance rate. And typically for AST data, this CI is constructed using this first one, Wilson's score method. Now, this is a binomial approach. It assumes that all samples are independent. In reality, we do know that it may not be exactly like that. All samples may not be independent. Why? Because there could be correlations within and between labs which are serving similar populations. Hence, some kind of confidence interval method, which is different from the traditional one, which assumes a binomial approach assuming independence of samples. So we may like to consider some other kind of CI method, since it is more appropriate because there is a likely correlation between labs which cater to similar populations. Hence, we have Wilson cluster robust CI method that can be considered for application because what it does, it treats each lab as a cluster and it accounts for this lack of independence. So this is just something which I wish to talk about. And also it's very important that whatever estimates are being generated or are being interpreted, they have to be interpreted with caution. Why? Because they have been made on data which is getting aggregated from different labs. And as I mentioned, when the data collector is going to the field, he's going to, ask every lab, are you, what's your affiliation? What's your level of working? Are you secondary level or tertiary or a primary? Are you affiliated to a non-profit, or you're a private or a government? So there is so much of different kinds of origin of that lab or affiliation of that lab. So we are getting data, and obviously all these labs will have a little bit of difference in their testing capability. Quality of testing may be different. So we have to be very mindful that although in the end we are aggregating data from labs with these varying testing capabilities, the AST results, of course, the AMR rates that we are saying, they have to be always interpreted with caution. Hence, recommendation for a Wilson cluster, robust. But again, a recommendation is, it can always, you can always go by whatever your project team thinks is appropriate, your epidemiologist or statistician thinks is appropriate. Please go with that. Just sharing a suggestion. And also, we must know that we cannot validate the AST data in a surveillance study, because you're not kind of doing active testing. You're getting data from somewhere and then going by the belief that this was done as per the declaration done by the lab, that they are following all quality standards. Of course, when you see the results and you do a review, you do get a feel of how much were they really adhering or not adhering to. So you do come to know that there could be variations. But you have to accept the data as is. And hence, this is, of course, a limitation of surveillance studies. And it's important to kind of just note that down. And now the last bit which I would like to talk about is, if you recall, we were also telling time and again when we were making the questionnaire, the data collector has to go to the clinic, and he has to go to the facility, and the pharmacy, of course to the lab also. But because he's going to so many different places, he's collecting all that different kinds of information. We can't let that information just sit on the paper, right, or on his device. You have to do some kind of assessment or analysis even on that thing. Now, what analysis will you do? So usually, I mean, again, we leave this for your teams to decide, but you can do multiple kinds of analysis. You can see, you can say, for example, the resistance rate in a particular site or a facility was, say, I'm just kind of giving some random example, it's 40% MRSA, and it was, so what kind of population actually was harboring that kind of a resistant bug? So if you have this information about the patients, you can then stratify further. It was coming from, say, patients of wound infections or patients of surgical site infections or whatever. So hence all these different information which the data collector actually collected now comes into further use. You can use this and then do various kinds of inferences. And of course, it's a wishful thinking that you will be getting information on all this, and hence you may really come up with really good recommendations tomorrow how to improve and mitigate AMR, but you may not get all this information. So we go with whatever we have and the best we can analyze, the best we can do correlations with. If you have this data, yes, we can. If we don't have it, we really can't do, but we can press for the recommendation tomorrow to the hospital team or the administrator. We didn't get data for all this. This is so vital. It would have helped us better in interpreting our resistance rates And these are basically the drivers of resistance. So the more information you have, the more you can think through, and this is not a long list, just a few important ones are there on the slide, but I'm sure you can think through many more possible drivers of resistance, and the data collector should be collecting information on that. So basically that's what is drivers, and this takes me back to my third or fourth slide that I presented on the first day, when we talked about why is AMR getting accelerated. So AMR is a natural phenomena, and it's getting accelerated, and we talked about various factors. So here, those factors can be, put into our variables of interest. And so we kind of, the whole circle comes to a close by putting all those things here. Even facility, and we spoke about that earlier today when I started off. It's good to know if the facility is implementing IPC program, AMS programs, because then you can again say that, okay, well, facility X was implementing and the rates were lesser. Facility Y was not implementing, the rates were higher, or maybe vice versa, and there are some other confounders we don't know. So we can kind of, have various kinds of interesting analysis, just not resistance rates. Even if you get genotypic information, that would be so valuable. If you can get that kind of data, just not phenotypic about the bacteria, you can then do various other kinds of analysis. Even the country level, I mean, this we have discussed. You can go over this list, and you can maybe in your future studies think about looking into this kind of, so you have the resistance rates, and we can do like if universal health coverage is there in the national program, or it's not there in the national program for a country. So all these things also help us to link various quality indicators, health quality indicators, with the level of resistance prevailing. I think this is all about what I wanted to convey on today's day, and we covered box number 6, which was data management. So by management, I'm actually taking the entire circle: collection, cleaning, review, analysis. So this whole is encompassed in today's slide. The next session we'll have is on Monday. We'll be talking about, that will be very brief. We'll just go over, how do you make a surveillance report? It will be very interesting. So all that we discussed so far, we'll show you, it will be a short presentation, but we'll show you how do you do report writing, how do you put the graphs over there, what's the structure, all those things. Again, only focused on AMR, not AMC or AMU. We'll be focusing on that. Yeah. So see you on Monday, not tomorrow.
Questions from the audience?
Thank you so much for the excellent talking. I have a question regarding data collection. Are there any templates you are recommending to have a sort of standardized form to not forget any variables and to be as complete as possible? Do you have any recommendations?
So when we normally these templates are, there is nothing standard, but in whatever work I have done earlier on those projects, we do have templates. It's in public domain, and I can of course share those links with you, and that's one. Other than that, I would again get back to HUNET, because HUNET of course has a huge, beautiful template. It's a software. Everything is there, but of course the data collector needs to be trained on how does he use that. So that is one of, in my experience, a very, very good data collection tool and a data analysis tool. It has both those components, but it needs, a training to understand how to go about that. So that's one, and then of course prior work in Africa, which has been done by various partners, out there also. It's all, there were lots of country reports which came out in the last 2 years. They too talk about the methodology and the various kinds of questionnaires and everything. Yeah.
We've got a question from the online audience. This is somebody writing us from Tanzania. They're considering a career as a data collector. They were just wondering if you had any thoughts on the educational background required for that, and also if it applies, if you could be a data collector outside of public health, or if this is mostly a public health career, if you have any thoughts.
So for AMR, are you talking about AMR training? You need to be actually part of a surveillance program, and as part of that program, you would be given the training. I believe there is community of practice also there by ASLN. So do check out there on their website. You really don't need to be trained totally on AMR. It's like on-job training. You'll understand. There is no prior qualification that you really need to know. It's pretty straightforward. Of course, there would be, it would be beneficial and desirable if you have some experience of working in the lab, in a microbiology setup. But even if you don't have it, that's perfectly fine. I mean, I was training data collectors earlier, and they came from varied background. I would say what's important is your ability to work on those, software and IT system and do troubleshooting. That's actually also very important. So it's very difficult for one person to have all the skills. So if you don't have the microbiology or the lab skills, but you have an IT skill, that also helps a lot.
Another question from the online audience. Somebody is noting that there is a microbiology lab shortage in some parts of the world, so it's not always possible to perform AST. Do you have any thoughts on how to overcome that in resource-limited regions?
We need, in fact, the whole purpose of these surveillance programs is to bring out those deficiencies, and we know as per recent research that has been published by various groups that the number of labs are drastically lacking in low, middle income and resource constrained settings. So that's the whole idea to highlight that when on one hand we are sitting, in big fora at international levels, and we're talking about AMR and we need to mitigate. On the other hand, we don't have. That's the stark difference. So we have to first look into capacity building. We need to look into infrastructure development, setting up labs. All boils down to, again, universal health coverage. So everything is connected. We need investments in just not making new labs, but also strengthening the existing labs, seeing to it that they have. So we talked about the QMS, quality management system, yesterday. It's just not having a lab, but also to ensure that they are following quality testing for AST reporting. So that also is so important. It needs investment.
Another question from the online audience. I think you mentioned that you need at least 30 isolates for meaningful analysis. This person is asking, where does the 30 come from?
This is a recommendation by a guideline, which is the CLSI guideline. Please look into that. They must have made this based on some methodology, some assessment. If you're interested, we can share that link with you. The 30 number comes from there. So we go by that because that's kind of the only guidance we have currently. And totally, I totally agree with you. Where does this 30 come from? It's a recommendation from CLSI, and CLSI is an authority. So we have to go back, and follow the authorities unless and until something new comes up. Eventually, I'm sure they put a lot of stats and various epidemiology rules, and they looked into various factors. Perhaps they would have looked into the prevailing burden of infections, and what's feasible to do, what's not feasible. They may have taken lots of factors and have come up with this number.
Another question from the online. No, actually, this is my question. You've talked a lot about the microbiology database and then also the clinical database. Is it safe to say that these are always going to be separate and they need to be joined, or what should we be aware of? Is this something that we will always have to unite, or are they sometimes presented together?
Ideally, yes, it's good, because it gives you the full picture. We just don't say resistance rate in E. coli versus cephalosporin is Y%, but we also add more value to that information, and we can add on it is Y% in this group of population, but it is Z% in this group. These are the various reasons why it's different. It could be maybe in a child having some kind of infection, it's more, or in a patient with cancer, it's less. So you see, these kinds of extra information just helps us to understand various drivers, and where can then the scissors be done, or mitigation be done. So more information, more value to that data. It's just not numbers. And genotypic, of course, is another thing. The more info we can get from as much of lab data, not necessarily phenotypic data, it just adds value.
And then another question, I was wondering if you had any general thoughts about the differences between collecting data in a hospital setting versus a community setting or any other smaller setting. Is there any thoughts that you want to share on that?
Yeah, so it is possible that you're doing it in a community hospital, and they are not having a very well-equipped lab. I'm just giving a random example. Maybe they're not following the quality practices, it's low resource setting, versus a hospital which is having more resources. They are adhering to accreditation guidelines, and they're certified. They're following all, they have audits in place, documentation. For sure, the reliability of results coming from there would be more than coming from there. Having said that, it may just be the reverse. Maybe in a community, it's a private lab, very well funded, faith-based. Maybe they have. So again, it just depends upon how much is are they emphasizing on the importance of AMR control in their setting. It can be, but for sure there'll be different situations everywhere.
Any further questions in the room? Please join me in thanking Dr. Kapoor. We'll be returning on Monday in this room at 9 a.m. Thank you.
Thank you.
Thank you.
Thank you.
Thank
Thank you
you.
for attending. Have a lovely weekend. Thank you.